Assalamu alaikum. Jazakumullah bil khair. I did not have lunch. Does that mean I'm the only one who's fully conscious? Okay. طيب. Thank you so much, Dr. Akbar, Dr. Shihab. First I'd like to thank GIS team for this great meeting, because I do believe that this kind of meeting represents a whole different domain of learning, which is peer-to-peer learning. And for every colleague who decided to share his or her complication, I say thank you very much. It takes courage and character to do so. So thank you so much. So my talk is, it's mostly scientific, so it's going to be a bit dull and harsh. So I decided to make it more appealing, just to share quick cases along the way with you, just to show you the difficulty of these clinical scenarios. Before lunch, I think the questions that was roaming around, those would be the most feared complication that any interventionalist fear. They said perforation. Luckily, it's extremely rare, but when we talk about no reflow, it's a different story. I do believe it's one of the nightmares. I will have a few points to address, including the incidence and the pathogenesis, predictors, clinical consequences, preventive measures, if any, and the management of no reflow. It's not new to us. This phenomenon has been described in the 60s and the early 70s and become increasingly recognizable actually after the PCI era took off in the 80s. It became more and more recognizable. TIMI flow grade 3 has been gold standard for the perfusion success, and no reflow was defined as TIMI flow less than 3, and as myocardial blush grade less than 3, or TIMI 3 and myocardial blush grade less than 2. How do you diagnose it? There's clinical diagnosis of the patient's chest pain improved, but the tools that we use usually EKG, coronary angiography, which is, I think, the main one that we rely on. Myocardial perfusion, myocardial contrast echocardiography, and MRI has been actually described, but more, I think, in the context of research and literature. Incidence, it depends how you look at it, but I do believe that it's underreported, and you get the feeling of that when you read about into the literature. You see variable, incidences from as few as 5% up to 60% of some of the seers. If any use TIMI 0 and 2, which usually reported up to 10% of primary PCI, if any use myocardial blush grade 0 and 1, which has been described to be present in up to 30% of patients, even with TIMI 3, okay, because now we're talking about different, not epicardial, but rather myocardial bed. It's particularly more common in degenerated vein grafts and following rotational atherectomy. So let's start out with case 1 quick. This patient in his, I think, mid to late 50s presented us with infralateral MI. I can see RCA as a CTO, and the culprit is rather decent size OM, and you can see collaterals to the right. So I went ahead, basically, some ballooning of that vessel. You can see there's a clot sitting in that, medium size to large OM. Okay, some ballooning the usual way, and this is after thrombus aspiration, which yielded minimal clot. We pushed the catheter distally, injected some vasodilator, glycoproteins, but nothing would give us actually decent flow. Luckily, the patient was asymptomatic. His chest pain settled, and also his ST segment improved significantly. So I decided throwing a stent there might not do this patient good in the acute setting. And the good thing that he had distal collaterals to the culprit artery, so hoping that will maintain viability of that vessel. Okay, just waited for 2 days. We just treated him. We decided to go with the deferred strategy, brought him in 48 hours and put a stent. It was straightforward. Luckily, it's open, and this is the best we can offer this patient, I think. The second case is rather, different. So again, this guy in his mid-50s, and his symptoms were vague. Okay, he thought that it's abdominal discomfort, so he came almost after 48 hours because he passed out and he was found to have ST segment elevation more clear in the inferior distribution, and he had complete heart block. You can see that we started with a temporary pacemaker and quickly did the subtotal occlusion. His RCA was hanging by thread with TIMI-1 flow. We opened it quickly, and basically during that, the patient had the first VT. We overdrive pacing because we had a pacemaker. He did okay, and when switched to the left, knowing that we had full diagnostic before that. You can see the LED has TIMI-1 to 2 at best, okay? His hemodynamics were soft, so again, we did gentle pre-dilatation with 2O balloon, and you can see on your right-hand side there is nothing. So even that TIMI-1 to 2 is gone, and his blood pressure was in the 90s. I should mention that his LVDP was 38. I have a habit of checking LVDP in most of my patients, and definitely in acute setting. I pushed the aspiration catheter. I did manual aspiration, did not yield much after several passes. I pushed it all the way down. You can see the flow goes back. So I know that it probably could be just distal vascular bed, but I thought there might be something in the area, so I decided to do IVUS. I'll just skip it to see if there's any big flap that would just close down every single time I do ballooning. So there's nothing, just heavy thrombus burden, soft plaque all the way to us. So at that time, when we were doing the IVUS, the patient has VT, VF, CPR, and basically we had to go. So I decided to go ahead and just put a stent quickly while we're doing that. But we ended up basically with refractory VT, VF, and we could not save the patient. Okay. So why does it happen? It's multifactorial phenomena, and usually when you read about in the literature, it's usually interrelated in a complex manner. It's just not one thing. It's multitude of different causes together. 5 different mechanisms has been well described in the literature, including individual susceptibility of microvascular dysfunction, pre-existing microvascular dysfunction, distal microthromboembolic phenomena, ischemic injury, and reperfusion injury. All in a complex manner lead to pathogen. This is a cartoon to show that. And when you think about it in a very simple term, you have somebody who's susceptible to that, okay? You have ischemic damage, okay? You have distal embolization, we start to fixing it, okay? Complicated by reperfusion, and that will lead to no reflow. If you're lucky enough, it will be transient. You can rectify them in the cath lab, and if you're unlucky, then it might be sustained and might eventually end up with catastrophic consequences. What are the factors that could increase the incidence of no reflow? I highlighted the important ones. You can see that lesion length is an important one with significant odds ratio. Thrombus grade, a significant one as well. Use of intra-aortic balloon pump before PCI is a significant predictor as well. Reperfusion time, as well as systolic blood pressure on presentation. So all these together would increase the risk of no reflow. Why is it important? Well, because of this diagram. So this data derived from thousands of patients from the NCDR, and it showed that in hospital mortality, that's a STEMI patient data, is almost 4 times those with no reflow. So in hospital mortality, reinfarction, cardiogenic shock, heart failure, all significantly increase if the patient developed no reflow. And is it peculiar to STEMI? Of course not. When you look also at the same data and you compare STEMI to non-STEMI, also no reflow has actually dire consequences in patients with non-STEMI patients with no reflow. You can see the mortality almost 4 times in non-STEMI with no reflow compared to good flow, as well as cardiogenic shock, which is almost 5 times, and heart failure 3-fold as well. So it's nasty. Now, when you look at the prognosis of it, it's just dire the way you look at whether with the angiography and ST segment elevation, myocardial flush. You can see, just look at the right side. Patient who had decent ST segment resolution with good blush grade had 1.2% mortality at 12 months, compared to 10% in patient who had poor ST segment resolution and 0 or 1 blush score. Again, That's conferred by different mortality. So we're dealing with a very dire complication consequences. The management, now unfortunately there's no consensus on how to manage this and no definite therapy. Prevention is extremely important in these cases, and usually we end up, to be practical, using different strategy in our practice. Modification of PCI is the thing that we could do if we have the luxury of doing that, and the cath lab that potentially might change the outcome. Available therapies slightly change the outcome. It might help, but the data on that is all over the place. Again, this is a very decent and recent attempt from a bunch of researchers looking at, they came up with this score. So they looked at the prediction of NR, it's called NORPASC risk score, and they came up with different clinical criteria. And in the initial cohort, as well as in the validation cohort, they concluded that the score of more than 8 or more had 22 and 27% risk of nasal flu. So that could be a good tool to keep it in our mind when we're dealing with our emergencies. What do I mean by modification of PCI? Thrombectomy should be used whenever is deemed suitable, especially invisible and large clots. Defer stenting should be considered, direct stenting, avoidance of post-dilatation, distal coronary administration pharmacological agent using microcatheter or aspiration catheter if used for thrombectomy. I think I will skip over these. When we talk about defer, it's probably one of the things that we use in the cath lab, but do we have a strong data to support that? So one of the first study that was published, but it was a small study, was defer stenting, and it showed actually in conclusion in high-risk STEMI patients, defer stenting in primary PCI reduced no reflow and increased myocardial salvage, okay? So that was around 100 patients altogether, but they could not actually reproduce that, okay? MIMI study after that, which is a bit larger than the first study, did not show any benefit, okay? And one of the reasons for that, they claimed that they used actually low-risk population to start with. So it would be difficult to show a difference, okay, if you have low-risk population. Defer, Dynamic 3, the first study, also showed no benefit. It was slightly larger than the first one. It's actually larger, was I think over 1,000 patients, did not show significant benefit. But when they, we'll come to that, one of the reasons is actually most of these studies, they're not consistent in terms of their outcome, because what do we mean by deferred? We're talking about a day or two or up to 7 weeks. So you can see that most of these studies were all over the place in terms of timing. There is a decent collaborative meta-analysis combining all data of these big deferred PCI studies, and you can show, it showed actually when they lump it together that no reflow improved with deferred strategy, okay? But was on the expenses of a trend, it wasn't statistically significant, but a trend at increased reinfarction. So it's trade-off, we should always keep it in mind. What can we do intra-procedural? To minimize no reflow, as I said before, no definite therapy combination strategies are very common practice, and these are the available medications in the cath lab. Glycoproteins, vasodilators include adenosine, cardinal, nitroprusside, calcium channel blockers, and more recently, epinephrine. I'll fast forward. Adenosine actually, again, when you look at the study, some of them are promising, some of these studies showed no benefit, etc. But again, lack of other options, okay, will usually force us to use it. There is a recent study that compared adenosine and nitroprusside, which I think are the most widely used agent in the cath lab. It's called Reopen MI, and it showed that the use of adenosine after thrombectomy showed actually better ST segment resolution and better outcome in those patients with less no reflow. So I'll fast forward and finish with epinephrine. Now we all know that use of epinephrine in the cath lab in patients with a STEMI is rather tricky, okay? but more and more recent studies showed actually a decent safety margin in those patients and became actually preferable agent when we use it in patients with high potential. You cannot use adenosine, you cannot use nitroprusside, so you can use epinephrine. And this is a study that was, they looked at its utility in, can I just have 1 minute? I'm almost done. Looking at the use of epinephrine in normotensive patients, okay? And they compared it to adenosine. You can see on the right-hand side that post-administration, patients who were treated with epinephrine actually had better TIMI 3 flow compared to those patients who received adenosine. So that's another agent in the cath lab. You can use it in time of need. So what would be the practical approach? Anticipation is key in these patients to at least to be prepared, and based on clinical data and angiographic data as well. Prevention is paramount. If you can prevent the occurrence of no reflow, then that's probably the best way. Thrombectomy should be widely used in those patients with visible and large clot, glycoprotein use, and vasodilator as well, and it should be administered distally if you think that upstream injection will not lead to good result. Modified PCI versus deferred strategy should be considered, and I should leave with a notion that in those patients with soft hemodynamics early on with the high likelihood of developing no reflow, we should consider hemodynamic support early on. Thank you so much.
Excellent. Thank you.